You can improve a lot of the cellulite as well. Her contour, the posture, a lot of things you can improve with the lower body lift.
Welcome to the Doc Malabar podcast. Plastic surgery, science, and cool stuff in between.
The patient comes, say, doctor, can you remove this? Yes, we can remove it. This is the result after the lower body lift. You can also improve the butt, the gluteus with the flap, has been described priorly. And you can improve a lot of the cellulite as well. Improve her contour, improve the posture. A lot of things you can improve with the lower body lift.
I have some questions. My experience with body lifts in general is that I don't recommend them. I feel that if you want to get a rather snug abdomen, they're going to have to be, it's going to be snug, it's going to be tight a little bit. They're going to be bent over for a few days to a week perhaps. But that puts a lot of tension on the back repair, the elevation of the buttocks. And I've seen patients come to me from elsewhere with a lot of dehiscence and wound problems of the back wound. What's your take on that, and how do you get around that?
Okay, so when I do the incision, I don't merge it, so I finish here. So the midline, there's no incision, so there's not, even if there's a tension, because that's the problem, the angle here. That's who we're gonna die. We have necrosis because of tension.
I see it at the top of the arc of the buttock. I see where, you know, it's like a lever arm when they go and sit, which they shouldn't be doing, that they just rip the top of that buttock incision. Again, I don't do these because I've always felt like you get a mediocre result front and back. Clearly, you have a great result. What are you doing differently than I'm seeing other people doing?
Yeah, the thing I do now, because most of these patients, they come from out of the state and they leave sooner than I recommended. So sometimes I make a variation. So let's say this incision, I bring it here, and the other one this here. So there's an island of skin which is not undermined. So basically there's no tension. So obviously some is gonna give. And one of the things is you cannot do a very aggressive skin removal in the front.
Right.
So if the patient has too much and they want the best result in the abdomen, then you need to split it.
Right. And that's what I do. I do my front first and my back 6 months later.
That's the best recommendation. And that's I tell them to the patient that's my preferred method as well.
Yeah.
But the problem is they don't want to come back.
Oftentimes they don't. I have patients from out of town, same thing. They want it all done in one shot. But it's tricky for at least in my hands and others I've seen for the back portion. Is just too much tension on it. So that's interesting, that keeping that midline not together. So that gives them a little bit of tension relaxation going laterally if you don't connect in the midline.
Yes, because most of the problem of necrosis and dehiscence is in here, in the midline.
Right.
So they have to bend over to protect the abdominal incision.
Right.
And vice versa. They have to stand up to protect their back.
Exactly. So which one is it?
So I tell the patients, you have to walk straight. So I won't be able to do too much removal of skin on the abdomen.
Right.
That won't give me a good result. Then I said, you need to split it. Some patients, they will do well if you do both simultaneously.
Mm-hmm.
But, and I use, the TED lock with, deep fascia, the superficial fascia, call it actually, anchoring. So the SFS, we call it. That helps a lot. So
it does. It does.
Heavy suture deep to give me that support. And one thing I do it is when I even during the surgery, just turning the patient, you might weaken that repair. So I put a long strips of tape, HEPA-fix, from here to here.
Right.
To give me an additional
support. Yeah.
There's also, if you have issues and you have some too much tension, there's method of closure or of support is called the top closure. This was invented by Maurice Topaz from Israel. Look at it, it's called the top closure. So it's an external device, doesn't, you can put this tape, and it's not a tape, the thing that you put it for colostomies. They get very adherent. There's a name for that.
Yeah, I'm blanking on that name as well, but I know what you're talking about.
Yeah, so you put it that, and then the top closure, you put a staple on that sheet that you put on the skin. So actually, it's a wide portion of the skin that's been supported or advanced, and then it's like a belt.
Yeah.
2 or 3 that can be put together gradually to close these incisions or give support.
Let's move on to breast. Let's talk about your owl lift.
This is the owl incision. Basically, this is a combination of the circumareolar, the perioral incision, and the vertical incision. So this is not a pure vertical, because the pure vertical leaves the keyhole for the areola still small. This is a little larger. And vertical, and I added up a small horizontal. This is just some examples.
I think we can talk for about 3 days, and I'm enraptured with your results and your techniques.
For me, it has been a pleasure and an honor to be part of your podcast.
Thanks for visiting. See you next time.